sharing experiences is really important, learning from each other, hearing from our expert speakers.
I want everyone to really take control of their health, because it's your body and your life, and if you're not in control of it, no one else will be.
Turns out that almost all pacemakers are completely fine to go through an MRI scanner.
Both septal ablation and surgical treatment show good results. It's safe, horrible.
HRT for many women is a lifesaver.
However, and it was a real shock, they told me I did need a transplant.
It's funny being a carer. You know, sometimes people don't take their medicines properly and you get cross at them. Why are you not taking your medicines?
I would say the next big stage in the development of this story was our understanding that this is, in many people, a genetic condition. So it's a heritable and transmissible disease.
So some of the pros of genetic testing are that we can find a causative gene change in some people.
So thank you so much for that kind introduction. You'll see here today that many of the talks focus on advances in the medical management of cardiomyopathy. So I think the fact that Cardiomyopathy UK have chosen to include a talk on exercise and lifestyle, and the very fact that this room is so full, tells me a couple of things. Firstly, we know it's very important, that it's an important part of managing our condition, and secondly, it's really important to you. So I'll start today by giving an overview of the current recommendations for exercise for those affected by cardiomyopathy. I'll be speaking about the main cardiomyopathies here, and that's hypertrophic cardiomyopathy, dilated and arrhythmogenic. I'm sure I don't have to tell you about the vast benefits for our physical and mental health of exercise. But you may understandably be worried about the risks because of your condition. Perhaps the risk of dangerous, abnormal heart rhythms, or the risk of disease progression. So today what we'll cover is how can we get the balance of all of the benefits of exercise with the least amount of risk. The focus in the guidelines is on aerobic exercise, but I do also want to talk about strength exercise, because I feel it does give us benefit, and because in my experience, it's an area that people feel less confident with. We'll go on to talk about what are some of the considerations if you have an implanted device, or perhaps you might be considering one in the future. And then importantly, if you're sitting here thinking, I know what I should be doing, but I'm not really doing it yet. How can I just get started with exercise? And then how can we keep going? How can we all make sure that these healthy habits last a lifetime? So let's start with the recommendations. So the recommendations I'll cover come from these internationally recognised documents that are based on the best available evidence, or if evidence is lacking, then consensus opinion from the experts in the field. So the recommendations that follow on the coming slides talk about different intensities of exercise. So I thought it would be good to start by just defining what those are and being really clear on those. But let's start on the far left of this slide. Sedentary behaviour is quite simply sitting, and we know that we should all do far less of it. The guidelines are that we should all try to spend less than 50% of our waking hours sitting, which, if we have a desk-based job and we commute by car, is not easy. And today we're going to be doing a lot of sitting. Light activity. So light activity for most of us will be our everyday activities. Things that we can do quite comfortably, things that feel quite easy. It might also include things like easy walking. You'll see yoga up there. I beg to differ. I think some forms of yoga are probably not light. Moderate intensity activity. So that is what we might consider a bit more energetic. This might make us feel a bit warm or a bit breathless. And then beyond moderate is vigorous. So there are two ways in which we can measure intensity. One of those is heart rate, and the other one is just how the exercise makes us feel. So let's cover heart rate first. A lot of people are now using devices to monitor heart rate, Apple Watches, and I'll cover that later on in the talk. But if you're trying to work out what heart rate should I be working at, the most straightforward way to do that is to do 220 minus your age, and that gives you your maximum heart rate. This is where people get out their phones and quickly calculate what their maximum is. And then you'll see here that less than 60% of your maximum is considered light. Roughly 60 to 80% of your maximum is moderate, over 80% is vigorous. Now be aware there is a little bit of error in the calculations because obviously not everyone of 60 years of age has the same maximum heart rate, but it is a good starting point. If you're on a beta blocker, you can probably confidently take off 20 or 30 beats based on the dose of beta blocker from your maximum heart rate. So just allow for that as well. So I mentioned earlier, the other way we can monitor exercise intensity is by how we feel. And once we get used to how our body feels when we exercise, it's very reliable, a really reliable tool. I would argue as reliable as heart rate. So the light activity, we're quite comfortable doing it. We're not at all breathless. We're not at all warm. The moderate intensity exercise, we're comfortably breathless. And that's a term I'll keep coming back to because I think it's really helpful. I can feel my breath, but I'm comfortable to carry on. And I can actually recover quite quickly too. Vigorous exercise would be exercise where we're more than comfortably breathless. We probably can't catch our breath between words easily, and it takes us quite a while to recover afterwards. Do remember, however, that exercise intensity is relative to your fitness. What I mean by this is if Mo Farah was doing a non-competitive run, he'd probably consider that light, whereas for us, the same pace would be vigorous. So as your fitness improves, you'll be able to do more at lower intensities. And if you still want to get the benefit from exercise, as your fitness improves, you need to up the intensity to still get the benefit. So next, the published guidelines all make these statements. And I think these are important to consider before we move on to the next slides. So exercise recommendations made to you should consider particular markers of increased risk, and I have got those on the next slide, following expert assessment. What that means is your cardiologist, when they have a conversation with you about exercise, should consider you as an individual, how you're presenting, signs and symptoms that you've got, your ECG findings, your MRI, all of those should be taken into account when they give you exercise recommendations. I'm going to ask for hands up. I'm going to ask you 2 questions. The first one is, when you last saw your cardiologist, did you ask about exercise? Yes, give me a hand up if that's a yes. Brilliant. Now only keep your hand up. Only keep your hand up if you felt the advice you got from your cardiologist was very clear and gave you helpful guidance going forwards. Right. You'll see about at least 50%, maybe more of those hands dropped. So that's a concern for me. So some people are getting advice on exercise. For most people, that advice is a little vague and a bit generic and isn't very helpful. So we're working on that because we know that not all cardiologists are experts in exercise. And despite all these published guidelines, it can be very challenging to get that advice into a 10-15 minute consultation. And it can fall off the end of the conversation after you've covered medications and investigations. We ask that that recommendation around exercise should be reviewed annually. So the advice you're giving soon after your diagnosis will probably change over the years. So that advice you're given about how much exercise is safe for you should be reviewed annually because it might change. And we know that young people probably should get advice more regularly than that because their condition can change more rapidly as they grow up. So there's quite a lot on this slide. I'll go through it slowly. So I've said already that when advising you on exercise, your consultant should consider those markers of increased risk. The ones at the top of this slide are just the main ones. There are more. But what they should do is look at the scans you've had, look at the symptoms you've had, look at your ECG, and they're looking for things that might put you more at risk of having dangerous heart rhythm problems or disease progression with exercise. We've heard already in previous talks that scar on your heart that's found on MRI can increase the risk of heart rhythm problems. So if we see scar, we're going to be a bit more cautious about how much exercise you do. We also know that the pumping function of your heart can interplay with problems with exercise. So if you've got a low ejection fraction, we're going to be more cautious. If you've had documented dangerous arrhythmias on ECGs, or you've got a cardiac device, again, we're going to be a bit more cautious. You'll see for the purpose of reviewing the exercise recommendations, we can broadly categorise ourselves into one of three groups. So we've got genotype positive but phenotype negative. So you carry the gene, but otherwise you're well, you've never had heart rhythm issues, and your scans are essentially normal. That's probably not many of us. The next category is that you've got some changes on your scan or some symptoms where you tick at least one, if not more, of those conditions or markers of increased risk at the top of the slide. And then the last group is those of you that tick maybe several of those markers of increased risk, and that's the group where we're going to be more cautious. So just consider which of those groups you might be in, because it has implications for the following slides. So we're going to start with hypertrophic cardiomyopathy. And hypertrophic cardiomyopathy is probably the one where we've got the most evidence. So we've got the most certainty about our exercise recommendations. With those with hypertrophic cardiomyopathy, we know that for too long, our exercise recommendations have actually been too cautious. And what that's meant is that some people haven't got the benefits of being active. And some people therefore have other health conditions because they've had quite low intensity of exercise over the years. However, there are still some for whom we would be cautious. So you can see for those who carry the gene for hypertrophic cardiomyopathy but don't have any significant structural or functional changes and are not in any way symptomatic, we'd say there's no restrictions. Actually, if you have the fitness and you want to participate in high intensity or competitive sport, you can go ahead. But that should be reviewed annually. And if you get any changes on any of your scans or you get symptoms on exercise, you should get advice before you continue. What about those who have got morphologically mild hypertrophic cardiomyopathy? So no markers of increased risk, and specifically no left ventricular outflow tract obstruction and no exercise-induced ventricular arrhythmias. You also can do all forms of exercise training, including high-intensity exercise, if you've got the fitness and you want to. But for those with any markers of increased risk, particularly those with left ventricular outflow tract obstruction, poor pumping function of the heart, or arrhythmias on exercise, we'd recommend actually you can benefit from low and moderate intensity exercise, but you shouldn't be doing high intensity. You shouldn't really be doing exercise that makes you overly breathless, and that can include things like competitive and team sports, because that could put you at risk of arrhythmias on exercise. Moving on to dilated and now non-dilated left ventricular cardiomyopathy. So as for hypertrophic, if you carry a gene, but you've no changes on your imaging and you have no symptoms that concern your consultant, as long as you don't have one of those high-risk genes, you again can proceed to participate in all forms of exercise, including high intensity if you wish to. Sorry, no, you should, with the exception of those high-risk genes. If you're asymptomatic, optimally treated, and again have no complex arrhythmias and good pumping function, so we would class that as an ejection fraction of over 50%, you can also proceed to all forms of exercise. If, however, you have markers of increased risk, and particularly if you have low pumping function, we'd encourage you to do low and moderate intensity exercise, so exercise that causes you to be comfortably breathless, but again avoid the high intensity. Arrhythmogenic cardiomyopathy. For those with arrhythmogenic cardiomyopathy, the advice is quite different. We know that with that particular cardiomyopathy, it's progressive, and we can see progressive replacement of myocardial tissue with fibrous and fatty tissue. That increases the risk of arrhythmias and over time can lead to poor pumping function of the heart. So the current recommendations are, for those with arrhythmogenic cardiomyopathy, even those who carry a gene but aren't yet displaying any signs and symptoms, they should avoid high intensity exercise. We'd also recommend avoiding large volumes of any intensity of exercise. So that's really anything more than an hour a day or maybe more than 7 hours in a week. For those who have no markers of increased risk, you can proceed cautiously with low to low end of moderate intensity exercise, but I would say if you then get any symptoms on exercise, get that reviewed. But for those with any markers of increased risk, which I know can be many of you, so you've had heart rhythm issues, you've got a device, then we would actually recommend avoiding even moderate intensity exercise. So that really means we're happy for you to be doing brisk walking, easy swimming, easy cycling, but we'd recommend not pushing harder with your heart rate and not doing higher intensity exercise, because there is evidence that actually that can contribute to the disease progression. We should recognise for those receiving a diagnosis of arrhythmogenic cardiomyopathy, that represents a significant change in their activity levels and can have a profound psychological effect, particularly for those who have previously been very active and really enjoyed sport. You might have concerns about other health conditions by reducing your physical activity. You might be worried about putting on weight. And actually many of those who've been really active and then get this diagnosis have to change their dietary patterns to avoid putting on weight. You might be worried about things like diabetes, but even taking account of those, we know the evidence suggests the risk of disease progression and increased arrhythmias from the condition, if you continue high intensity exercise, is greater than the risk of other health conditions by lowering your intensity. So if you have got arrhythmogenic cardiomyopathy and you've not yet received exercise advice from your team, do come and chat to me at the end of the talk. I feel it's really important that you can get benefits from being active. And I've worked with individuals where I've steered them towards other forms of activity, such as strength training, resistance training, yoga, ways to move your body and feel good about moving and get some benefits from that without getting the risks associated with the aerobic types of exercise. So how can all of us, regardless of which cardiomyopathy we've got, make exercise safer? There's a few key principles here I'm just going to talk through and help you understand why these are important. So warm-up is just what we do at the beginning of an exercise session. So if we're going to do some exercise that's going to make us warm or breathless, it's important to go into that gradually. What's happening to your body when you warm up and go into exercise gradually is you're allowing your heart rate to increase more slowly. You're allowing the blood to get out to your muscles and to the right places. And you're allowing your whole body to get ready for that exercise session. And you're much less likely to have rhythm problems if you start slowly rather than too quickly. So as an example, if your exercise is going for a brisk walk, make the first few minutes an easy pace. If you're going for a bike ride, don't start on a hill, start on the flat and just gradually ease into that exercise. How long you warm up for will be proportional to how long you're going to exercise for. So if you're exercising for half an hour, you probably want to be warming up for 10 minutes. If it's a shorter session, you can shorten the warm up. But just go into every activity gradually. Start low, go slow. So don't be too ambitious when you start. Be patient with your body. Start with a low intensity and build gradually in terms of how long you're exercising for, how often and how hard. Just go slowly with your progression. Take your time. You're much less likely to have injuries. You're also more likely to be successful with continuing with that exercise. And then cool down, I think, is the bit that's missed most often. We're all time poor. We're all in a bit of a rush. We do an exercise session at the gym and we think, I'll just squeeze in a bit more and then I'll head straight to the shower. Try and make sure at the end of each exercise session that you keep your feet moving till you've caught your breath. What's happening is that's allowing your heart rate to come down gradually, and it's allowing all the adrenaline that your body's naturally produced during exercise to be reabsorbed from your bloodstream, and you're much less likely to have heart rhythm problems. So start gradually, finish gradually. Keep your feet moving till you've caught your breath. At the end of a cycle ride, finish on the flat. Make the pace nice and easy. Before you head home, slow down the pace of the walking, so by the time you've got to your front door, you've caught your breath. Simple changes, but hopefully make it safer. You shouldn't get symptoms on exercise. You should never get chest pain on exercise. That's a reason to stop and ask your team what you should be doing about that. You shouldn't get palpitations or feel dizzy on exercise. Those are not normal. Don't carry on. We're going to talk a bit about strength training, but importantly with any exercise, don't breath hold. If you go to lift something and it's too heavy that you have to hold your breath, it's too much for you. And clearly exercising when you're not well is not a good idea, particularly if you have if you're vulnerable to holding on to fluid. So if you're someone who's on diuretics and has a tendency to have swollen ankles, if you have episodes where your weight goes up, you're breathless and your ankles are swollen, that's not a time to exercise. The cautions are not absolute no's, they're just things to be aware of. So it's very challenging for our body to move between different postures. So if you're doing an exercise in standing and then you go quickly onto the floor and then back up again, that's very demanding for your heart and your lungs. So some people might manage it and feel well, but for other people that will make them feel quite dizzy. And it's probably something we should avoid doing and find other ways to do those exercises. The same goes for sprints. So some of you, I've told you shouldn't do high intensity exercise, but even for those who can, maybe try and avoid the sudden exertions without the warm-up, because again, that's very demanding on the body. And hot weather, not a problem we have in this country apart from about a week in August, am I right? But maybe when you're abroad, you're somewhere warm. So I would say if you are exercising somewhere warm, or that week in July, exercise in the cooler part of the day. Don't exercise in the middle of the day when the sun's out and it's very hot. Stay hydrated. Even if you're on a fluid restriction, drink extra water if you're sweating, because it's when we get dehydrated that we can be at extra risk of rhythm issues. So what about strength training? I said I would mention it. So far we've talked mostly around aerobic exercise. And strength training might be something you've heard of. You've heard it's a good idea, but maybe you're feeling a bit less confident about how to get started and how to do it safely. So strength training might include machines, these things at the gym. It might include free weights or maybe some home exercise equipment. All of those are good. All of those are really, really good options. It might also include something called body weight training, where you just use the weight of your own body against gravity. Squats are a good example, really good exercise. So any movement where you're lifting, pushing, pulling a load would be considered strength training. But perhaps it's not just about weights in the gym. What other things do we do in our everyday life where we lift, push and pull loads? So I'd suggest these kind of activities, don't avoid doing them. Try and keep doing them because they keep your muscles strong and they improve your bone density. And if you're unsure about doing strength training and you want to do something at home with no or minimal equipment, the British Heart Foundation have just released a really simple introduction to strength training. This is my colleague Jack, he's great. He'll be really pleased that he's got a shout out on this presentation. But it's some really nice videos you can follow along with at home. They're progressive, so they start with no weight at all and they introduce ways to introduce some home equipment for weight. But a really nice starter point for some of you. And just a few principles around strength training. We don't need to do it every day. There's a tick. Twice or maybe 3 times a week is about right, because what that allows for is some recovery days where your muscles are recovering from the exercise you've done the day before. So start maybe just twice a week doing something. In terms of how much should we lift, 2 to 3 sets of 8 to 15 repetitions is about right. Rest between sets to let your muscles recover. You should feel like you've got 2 to 3 reps in reserve. So you can manage 2 to 3 more, but not many more. If you tell me you can lift a weight 30 times, it won't be giving you strength gains. So cut down a little bit and increase the load. But then as you get stronger, increase the load. I've said about avoiding breath holds as well. What about exercising water? I've included this because in previous years it's always been a question, so I'm just trying to get ahead of the questions. So exercise in water can be really beneficial. We know that for many people they really enjoy being in water. They find it easier to move, even if they've got knee, hip or back problems. They feel well supported and they just enjoy it. What we should know is that there is an effect of being immersed in water on our heart and lungs. So when we immerse ourselves in water, whether that be a swimming pool or a bath up to our neck, the pressure of the water on the outside of your body, called hydrostatic pressure, pushes all your normal body fluid towards your heart and lungs. So that happens for everyone. So when you're immersed in water, your heart and lungs are working harder than when you're on land. And then you add in exercise and that's an extra load. So we should just be aware of that. And I would say if you've got a heart condition, try exercise in water, but be aware of how you feel whilst you're doing it in terms of energy levels and breathing, and how you feel later in the day. And if you find it's the water-based exercise that makes you tired and breathless, it might not be something that's right for you, and it might not be something your heart's coping with. If you can sleep with 1 or 2 pillows comfortably, you probably will manage exercise-based water-based exercise. If you find you need 3 or 4 pillows or you struggle to lie flat, you may not. A few things to get going. Start with the shallow end, get in and allow your body to get used to that water immersion gradually. So get in, walk up and down the shallow end if you can, and then gradually go deeper. The same getting out, get out more gradually. What about monitors? Do you know how hard it was to find a picture of heart rate monitors without a brand on it? Near impossible. So I'm not endorsing particular brands, but I've tried to include a few there. The reliability of heart rate monitors has improved hugely in the last 5 years. We used to say that wrist-based heart rate monitoring was pretty terrible and you had to have a chest strap. Actually now, wrist-based monitoring is about 95% accurate. Chest strap is nearer 98%. So I'd say for the convenience of a wrist-based heart rate monitor, it's not bad. And it can be really useful. I'd say it's particularly useful for 2 groups of people. For people who know they have a tendency to push it a bit too hard, it's useful to have the number to rein you in. And for people who have a tendency to not quite work hard enough, quite useful to make you do a bit more. But everybody else, as long as you're good at knowing how hard your heart is working by how your breathing feels, I wouldn't say it's essential. So don't feel you have to rush out and put one on your Christmas list. It can be a useful guide. That's your rate of perceived exertion chart. If you've done cardiac rehabilitation, you'll know what that is. That's just a way of using our feelings of exertion to monitor how we're feeling. Step counts. We all love step counts. We like to boast when our step count's amazing, don't we? I'd say step count can be really useful to monitor your general physical activity levels. However, be mindful it doesn't give us any indication of the intensity of that exercise. So I can do 10,000 steps a day but not break a sweat once. So just be mindful that step count isn't everything. It's useful for general activity, but it doesn't tell me if you're doing structured physical activity that's going to give you those added health benefits. And what about exercise and implanted devices? So maybe you're sitting here and you've already got a device and you're not quite sure what that means for exercise. Or you've been told you might need one in the future and you're a bit nervous of what that might mean for exercise. The implications for exercise really depend on what type of device you have. Most of you will probably have a device with transvenous leads, so leads that go into the heart. If you've got a device that's implanted up here or up here, it has leads that go into the heart. Or maybe you've got the one on the other side of the slide that's called subcutaneous ICD that's just next to your chest wall under your armpit. That one has got leads that sit next to but don't go into the heart. The reason there's a difference for exercise is for the device where you've got leads into the heart, for the first 4 to 6 weeks, we'd say don't lift your arm above shoulder height and don't reach behind you too far. That's because when we first put those leads into the heart, we want them to embed into the heart muscle. Beyond that 6 weeks, you can do any shoulder movement you like. Don't restrict it because you will get a frozen shoulder. However, if you do sports that require you to do very repetitive, very end of range movements, that slightly increases your risk of lead failure. So we'd probably recommend not doing competitive rowing, where you're really pulling your arm back repetitively very, very far. If you play tennis and you're left-handed, I maybe would just exercise some caution because when you go to serve, that's right at the top of the range and it's very repetitive. But otherwise, everyday activities are unrestricted. With the subcutaneous ICD, there are no shoulder restrictions. For the first few weeks, you will be too sore to use your arm much and lift and carry much. But once it gets comfortable, there's no restrictions. What about the second question? People worry that my device might see a high exercising heart rate and shock me. The good news is these devices are incredibly clever. They're continually monitoring your heart rate and rhythm. They know you well. They know that last time you exercised and the heart rate went a bit high with exercise, it was absolutely fine, it stayed steady and it came right back down again. So it's very, very unlikely the device will think that an exercising heart rate is an arrhythmia. There's a big difference electrically between a sinus tachycardia that we see with exercise and a ventricular tachycardia that's dangerous. They're very different to the device and it knows the difference. What you should do is stay below the shock thresholds that have been set for you. Typically they're very high. They're often in the range of 180 or 200 beats. And it's unlikely you'll get there with exercise, especially if you're on a beta blocker. But if I have a patient with a device come to me, I like to know what those shock thresholds are, and then I keep them below those shock thresholds when they're exercising by about 10 to 20 beats. What about contact sport? If you tell me you want to go back to rugby, I would say absolutely do, if that's your sport and you enjoy it. And I haven't told you you can't do high intensity exercise, but there are garments you can wear that have a little shield that sits over the device to protect it. Not because the device is going to get harmed, it's a thick metal box that is very robust. I'm more worried about a musculoskeletal injury you might get when you come into contact with another player. So I think we shouldn't be restricting those types of activities if they're important to you, but just make some extra considerations to keep them safe. Cardiac rehabilitation. I know in the previous talk I was in, Jerry Carwhite said, go to your GP and ask for a referral. I'm sure many of you have done that. The reality is that not enough people with heart failure and cardiomyopathy get access to cardiac rehabilitation. There are complex reasons why that's still the case. Some of it is commissioning and funding. Some of it is not having the right referral pathways in place. Some of it is confidence with the staff. But I would encourage you to ask. Ask your specialist nurse, ask your cardiologist, ask your GP, because the patient voice matters. Keep banging the drum. As healthcare professionals, we're doing all we can to try and increase the referral pathways. BACPR and Cardiomyopathy UK are currently working on a couple of projects around this. But as the patient, do ask, partly because it might not be at the front of the mind of the cardiologist you're seeing or the nurse. Oh, actually, now you mention it, I can do that. I can refer you. And partly because, as I said, the patient voice is important. There's a QR code there where you can find your local cardiac rehab program. You can also self-refer. You don't need a clinical referral. You can self-refer. And if the rehab team says they'll take you, all they'll ask is for you to send them the most recent letter from your team so they're fully aware of your history. And cardiac rehab is not just about exercise. Cardiac rehab is about getting the support for your wider heart health. So you should get access to a dietitian and talk about nutrition. You should get access to some psychology and support your mental health. And importantly, it's a good way to access peer support. Even if the other people in that group haven't got cardiomyopathy, they've had a new heart diagnosis and had treatments and had devices. And actually, there's a lot of shared experience in those journeys. So how do we get started? So if you know what you should be doing, but you're not quite as active as you'd like to be, here are a few tips. Start by reducing our sitting time. Think about a typical day and think about ways in which you can break up your sitting time. Think about ways in which you can just build more activity into your day. Try taking the stairs rather than the lift or the escalator. Try walking a bit further rather than doing car journeys all the time. That does make a real difference. And when you first start exercising, start with little and often. It's much better tolerated than big long bouts of exercise. If you've got low fitness levels, a short 5-10 minute walk in the morning, same in the afternoon, is going to be better tolerated than one big long walk. And then gradually as you get fitter, you'll be able to build up the duration. Choosing something you enjoy doing is really key. Thinking about whether you prefer to be active indoors or outdoors, whether you prefer to be with others or on your own, can all help you choose activities that you're more likely to carry on doing. As healthcare professionals, when we're supporting people to make behaviour change, we typically focus on helping them gain new knowledge and new skills. In fact, we bombard you with leaflets. We love a leaflet. Because if I tell you exercise is good for you, clearly you're going to do it. Am I right? Does that work? No. What does work? What should we be doing to help ourselves make behaviour changes? Habits. Habits change much more than knowledge. So as healthcare professionals, what we should be doing, rather than giving you knowledge about the benefits of exercise, is we should be helping you make some healthy habits. So to create sustained behaviour change, whether it be exercise or healthy eating, we rely on habit formation. So a habit is quite simply a behaviour that we repeat enough times for it to become automatic. So it'll often start as a routine, which maybe requires a bit of effort, but over time, with enough practice, routines become habits. So here's a few tips to create good habits. If you can make cues that remind you about the habit you want to form, you're more likely to get started. If you can make the habit attractive, you're more likely to crave it. If you can make it easy to do, you're more likely to do it. And if you can make it satisfying, you're more likely to do it again. So let's start with make it obvious. To begin with, we need to just become aware of our habits. Think about things we're doing automatically already, and then use something called habit stacking, where we can add a good, healthy behaviour onto something we do already. So I might wake up in the morning and the first thing I do is I come down the stairs and I click on the kettle for that cup of tea. I don't have to think about doing that, it's automatic. So I can add something onto it. Whilst I'm waiting for the kettle to boil, I can do 10 squats. Make it attractive. With exercise, the most obvious way to make exercise attractive to us is to choose something we enjoy doing. If we enjoy the company of others, choose a class. If we enjoy being outdoors, do something outside. You get the point. Make it enjoyable. And I think most importantly, make it easy. Take out all the friction. Remove as many excuses as possible. Put your gym bag by the front door the night before. Set the alarm 5 minutes earlier. Choose a class that doesn't clash with other commitments. And then make it satisfying. We're hardwired to do things for instant reward. Have you ever noticed bad habits give you an instant reward? That bite of chocolate bar is immensely satisfying straight away. Healthy habits seem to give us a reward that doesn't come straight away. So maybe you can add something on. Going for a swim, you have 5 minutes in the jacuzzi at the end. That's the reward. Or maybe even the nice warm shower is the reward. When we exercise, it releases endorphins. So when patients I work with tell me at the end of a workout, they feel really good. My energy's good. I feel mentally good. We talk about that to remind ourselves that next time we come, we'll feel the same way. And that can help habits form. So I'm just going to finish on a few things. Make exercise so easy you can't say no. So some of these will work for you. Some people are morning people, then schedule the exercise in the morning. Some of you aren't. Choose a time of day that suits you. So maybe have a look at that. If you go for a walk, listen to a podcast. That's the enjoyable bit, the satisfying bit. So in summary, exercise has lots of broad health and wellbeing benefits for all of us. For most of us, it's absolutely safe to be doing low to moderate intensity exercise. For some of us, we can actually do high intensity if we've got the fitness, but this should follow individual evaluation. And there are really simple ways in which we can make it safe. Self-refer to cardiac rehab.
Thank you so much, Helen. Brilliant talk. Now, no questions have reached my desk, but I bet there are some burning questions out there. So Becca's going to come round and gather up your questions. I was really interested to hear there what you said about some protection for people who want to carry on playing contact sports. That's something I haven't heard of.
Yeah, there's a company in this country actually that provide garments, t-shirts with protective, very strong layers that mean you can carry on with those sports.
Really important for mental health often to carry on your sport. Okay, I'm going to sit down here and look through these. If you've got any more questions, keep your hand up. Becca will come and grab them.
Oh, I don't like the sound of this
one.
Well,
okay, I'll just read it out straight. If you have markers of increased risk and should be concentrating on low impact exercise, how do you perform effective strength training? So I'm presuming this is someone with arrhythmic risk.
Yeah, it's a good question. Just to clarify, it's low intensity, not low impact. Low impact would be around the pressure or weight you put through joints. But if we're talking about low intensity exercise, so that would be at lower heart rates, it is really possible to do strength training at lower heart rates. And actually, typically what we see, if you compare an aerobic exercise session, walking on the treadmill, cycling, with a resistance training exercise session, as long as the reps and sets are appropriate, so 8 to 15 reps, not your 3 reps, actually heart rate and blood pressure is a lot lower for strength training, so it can be done a lot more safely for people with cardiomyopathy. The way to keep it safe is to make sure you're lifting the right load. So as we said, if you can lift a load 8 to 15 reps, 2 to 3 sets, it's the right load for you. If you can only lift it 3 times, it's too heavy, so start a bit lighter. Allow rest between the sets to let your heart rate come back down, because it will come up a bit during the exercise, but just be a bit more patient with yourself and give rest between to let the heart rate come back down. And that's where the heart rate monitor might be useful, just to keep checking in and check it's come back down in between. And then avoiding that breath holding. So avoid breath holding with exercise. Do most of your strength training upright if you can. It's a lot easier on the body than having your head down and your legs in the air. So stay upright, use machines. Machines are a great way to start because you're much less likely to injure yourself. If you set up the machine right for yourself, in terms of getting the seat height right, the machine is automatically set up that you're less likely to injure yourself. So if you're in a gym, start with machines, then move to free weights, which require a bit more core strength.
Thank you. Excellent answer there. Someone's asked a question here saying that their exercise tolerance has significantly decreased, so they were able to walk around and do housework, and now they're forced to be much more sedentary, and they're asking about ideas to help them remain mobile. So they're thinking about doing some exercises on the bed, and is there any other advice for that?
Yeah, that's a really, really good question. I would say the exercises I signposted you to at the British Heart Foundation are absolutely appropriate for that level. The starting point for those exercises would be quite low, so start with those. Certainly doing exercise little and often during the day, being active during the day, trying to use the stairs, trying to do some standing at home for tasks, because sometimes when our energy levels and our exercise intolerance gets low, it spirals down to the point where even daily activities are hard. So I think when you're at that point, you've got to balance activity with energy conservation. You've got to listen to your body each day. You've got to pace yourself throughout the day and throughout the week. So as an example, if I've got a lot of housework tasks to do, rather than doing them all in one go and trying to finish them off in the morning, I might spread them out throughout the day with rests in between. And therefore, over time, my activity levels will gradually go back up rather than spiralling down. If activities we do exhaust us to the point where we need a day off in between, often what happens is you spiral down in terms of exercise tolerance and energy levels. But if you're trying to be a bit more consistent with how much you do, so on the good days you don't overdo it, and on the bad days you do something, you often find a better trajectory going forwards. I hope that helps.
Yeah, that's brilliant. Okay, a couple of people have asked questions which you touched on a little bit. So yoga poses, are there any poses that should be avoided in HCM? And also someone else is asking questions about restriction in strength exercises like lifting above the shoulder. So let's just revisit that.
Brilliant, great questions. I would say things like yoga poses, it does very much depend on your condition and how you're affected. I would say if you're able to do something without symptoms, you're probably safe to do it because your body is coping with that position. So for example, with yoga, we worry about head down, maybe downward dog positions. If you do that, and when you do it, you get quite lightheaded and you come back up and you don't feel well, your body is not coping with that position. Whereas if you do it and you feel absolutely fine, you've got no dizziness, no chest pain, I would say you're safe to do it. It is more demanding on the body to do an exercise where you've got your head down and then you come back up. But if you feel well whilst you're doing it, I wouldn't worry about you. If it makes you feel unwell, don't do it. Strength training.
Lifting weights above your head.
Yes. So historically, we got very worried about lifting over the head. Don't do it. However, we all have to change light bulbs. We all have to put the washing out on the line. We all have cereal boxes up in the high cupboard. So in our daily activities, we do have to lift over our head. So it is really important that we've got the strength to do that. What I would say is, if you feel you're weak in lifting your arms over your head, start by low loads. So start by doing some overweight lifting. Doesn't have to be in the gym. Pick up a water bottle or two and do some lifting over your head. But do it where you're moving your arms, because that's a lot less tiring on your body than holding it statically. So sustained overhead lifting is again quite demanding for the body. Basically, the heart has to work quite hard to pump the blood up that high and keep it there, very broadly. So sustained overhead lifting is very demanding. So start with movement, overhead lifting where you're moving your arms with low loads, build up the load gradually, and you should find it becomes easier. I wouldn't say avoid overhead lifting, just get the load right and the repetitions right and build up slowly. Lovely. If you have a job that involves you doing sustained overhead lifting and you find that really hard work and it makes you breathless or dizzy, you might have to rethink that at work because it may not be appropriate for you to be doing sustained overhead lifting. I'm thinking painter decorators, sustained holding your arm over your head. For you with your health condition, I'd have a chat with your medical team because that might not be appropriate for you going forwards.
Brilliant. Listen to your body. Okay, the heart is a muscle. Can weight-bearing exercise make the heart thicker? So this patient might have HCM, be wondering.
Yes,
about that.
Good question. It prompts me also to answer another question that often people ask me. The heart's a muscle. Muscles get stronger and better when we exercise them. If I exercise, will my heart muscle get stronger and better and fitter? No. Your heart muscle, if you have a cardiomyopathy, your heart muscle condition is there. Exercise doesn't actually significantly change what your heart muscle looks like. Doesn't make it thicker, better, doesn't make it pump stronger. However, when you exercise over time, you get less breathless. You can climb the stairs more easily. You're not as restricted. That's not to do with your heart muscle changing. That's to do with the peripheral changes that happen. So when we exercise, our muscles in our arms and legs get stronger. They also get more efficient. So they get better at pulling oxygen out of your blood. They get better at getting rid of waste products. The blood vessels in your muscles get better at vasodilating and constricting at the right times. So because our peripheries get more efficient, there's not so much strain on our heart and lungs, so we can do more without getting breathless. But it's not because of central changes, it's because of peripheral changes. In terms of hypertrophic cardiomyopathy and worry about lifting weights, as long as you stick to the guidance I've given you about weight training and avoid things like power lifting, where you're lifting 1 or 2 very heavy reps, it's safe, it won't make your heart muscle thicker or stronger.
Lovely. And a nice follow-on question from that is, could exercising when I have HCM actually help reduce the onset of and the progression of HCM?
Good question. I'm not aware of evidence where it delays progression of that condition. However, it will improve your overall health. And if by exercising regularly you don't put on weight over time, that's going to really help your heart. Because we know that people who become obese because they don't exercise have worse outcomes from their hypertrophic cardiomyopathy. So it's not going to delay progression of your actual disease, but it's going to keep you in better overall health, which means that your lifelong prognosis is going to be better.
Great. Someone here with DCM is considering running a marathon. Sounds like I'd go to my specialist, but do you want to say something about that?
Yes, I would, because as we saw on the slides, it very much depends on your condition and how you present. For the vast majority of patients with a diagnosed dilated cardiomyopathy, high intensity endurance training, like marathon running, probably wouldn't be sensible. However, I feel that should be a shared decision with your consultant. I never feel I should tell someone an absolute no, and I don't think your consultant should either. I think what they should tell you is what are the risks and what are the benefits. And can you get the benefits of exercise from maybe lower intensity, reduced volumes of exercise without running marathons? Probably. So it's very difficult when someone's very, very determined to do something specific. But I would say have a conversation with your consultant about that. For the vast majority, it's probably unwise in terms of avoiding high intensity and high volumes of exercise. But then there might be an individual where it is safe.
Yeah, lovely. And this is a good follow-on question. Someone asking how their left ventricular ejection fraction relates to how much exercise they should and can do.
That is a brilliant question. What we see actually is a very poor correlation between left ventricular ejection fraction and functional capacity. You would assume there's a direct correlation, there really isn't. I've had people come to me who've got an ejection fraction of 15% and have comfortably jogged up and down the room. And then people who have got an ejection fraction of 50% and can barely walk 10 yards. And it's because of the peripheral adaptations. So if someone has remained active and they've got good, strong muscles in their arms and legs that are functioning really well, that can compensate hugely for a poor pumping heart. Whereas if they've got very inactive and weak, they can't compensate for that. And they get they have reduced exercise tolerance. So no, I'd say there's often a poor correlation. For someone, however, with a poor pumping function of their heart, very low ejection fraction, below 20%, the increase of rhythm problems is higher. So I'd say there's a poor correlation between ejection fraction and functional capacity or physical capacity, but there is an increased risk if you've got very low ejection fraction.
Okay, we've got quite a few questions here, some related to genes, and I think really the underlying question is about arrhythmic risk. So quite a good one here is just about someone's got a bit of a low ejection fraction, they definitely have arrhythmia. Can they do a kind of a low intensity aerobic class?
Yes, I mean, as we said, intensity is relative to fitness. So if someone tells me they want to do a low intensity aerobic class, it depends on your fitness, how intense that class is for you. If you've got quite good baseline fitness, then you might manage an aerobic class very easily. If you've got quite poor fitness, an aerobic class might be really challenging. I'd say if you want to look at classes, always talk to the instructor before the class starts and just explain, I've got a heart condition, I've had a chat with my doctor, they're happy for me to have a go at this, but I'm probably going to be wiser to stick to some of the easier options, and they will guide you towards starting that class gradually.
Okay, lovely. And then another kind of arrhythmic question is a teenage patient who's got arrhythmogenic cardiomyopathy, and they've got a gene for that, a gene positive, but they're not having any symptoms, and they want to know what the guidelines are. I know you touched on it a little bit, and it's a tricky area.
It's a very tricky area, especially when you're diagnosed so young. We want to keep you well for as long as possible. We want to do all we can to enable you to get the benefits of being active without the risks of arrhythmia and disease progression. So the current guidance for someone like that would be not to do anything above low intensity exercise. So we'd be guiding you towards brisk walking, easy swimming, easy cycling. We'd be encouraging you to do things where you don't get overly breathless with exercise and where your training heart rate is less than 60% of your maximum. So I'd say use a heart rate monitor to guide you. It's really, really challenging. You will need probably some psychological support to deal with that diagnosis and the impact it will have on how active you want to be. Happy for that individual to come and speak to me at the end if they want to, especially if they haven't got any advice on exercise from their own team. It's a really difficult one. But we would say that if that person wants to do exercise that makes them warm and breathless, or wants to do any big volumes of exercise, the risk is that their disease progresses more rapidly and they're more likely to get rhythm problems on exercise.
Excellent. There's a couple more very specific gene-related exercise questions, which I think I would say come and speak to myself and Helen maybe afterwards. Yeah. You know, people being tight in gene positive and their risks. I think we should do that separately. Yeah. Okay. Well, you didn't talk about this, but have you got any thoughts on weight loss medications? Weygovy and HCM is the question. Does anyone ask you about that?
I do get asked about that. And I think it's obviously very new. They're new drugs. We're seeing lots of benefits for people, particularly people who really struggle, who've tried already with dietary change and exercise and struggled. I think they're a really viable option for people. What we do know is that when you lose weight quite quickly, you don't just lose fat, you lose muscle. And we want to try and avoid that because we know muscle is really important for maintaining our exercise tolerance. So I say if you're considering those drugs, do get in the habit of doing some regular strength training, use the guidance I've given you to try and attenuate that muscle loss, because we lose out when we lose muscle. We also know that if you're wanting to exercise for weight loss, exercise alone for weight loss is very ineffective. Typically in about 6 months, we lose 2 to 3 kilos. And then in the following 6 months, we put half of that back on. So it's a pity my colleague Tom's not here, because we know that if you're looking for weight loss, a combined approach of dietary change and exercise is much more successful. When we exercise, we increase our energy consumption and we get hungrier. And so we eat more. And so we don't lose weight, basically. So you have to make dietary changes and be active to lose weight.
Excellent. Okay, there's so many great questions, but I'm just going to ask this as the final one. So this is about devices, Helen. They monitor lots of stuff. Someone's got an Apple Watch and they want to know about their VO2 and how much notice they should take of it. Now, do you want to answer that question?
I'm happy to have a go. I think in terms of, I spoke earlier about how the devices have got lots better at monitoring heart rate than they used to. A new function they seem to be monitoring is VO2, which is basically an indicator of your fitness. I'm not convinced on the over-reliability of that function. I think it will improve over time. I'd suggest not getting too obsessed with it. I'd go on how fit you feel. And over time, as you exercise more, you feel you can do more with less activity. I think VO2 it could be a useful marker of fitness, but I think we're undecided about how reliable it is.
Great. Okay, I'm sorry we can't answer all the questions, but Helen did very kindly say that she was available if you want to ask her some of those questions. I'm hanging on to all these questions because we'll just make note of, themes that we can perhaps help with. So for now, thank you so much, Helen. Absolutely invaluable.